Today's class is on pit and fissure sealants. Coming to the definition, it is defined as a small pinpoint depression located at the junction of developmental grooves or at terminals of those grooves. The central pit describes a landmark in the central fossa of the molars where developmental grooves joins. It was given by Ash in 1990. Coming to the fissures, it is defined as the deep clefts between adjoining cusps. They provide areas for retention of caries producing agents. These agents occur on occlusal surface of the molars and premolars with tortuous configuration that are difficult to assess from surfaces. These areas are impossible to clean and highly susceptible to advancement of caries. It was given by Owens in 1990. Coming to the morphology, there are various patterns of pits and fissure sealants. According to Nagona in 1961, he classified it as U, V, I, K and inverted Y shape. In that, U pattern shows 14% prevalence and V pattern shows 34% prevalence, which is more. I pattern shows a 19% prevalence and K pattern shows 26% prevalence. And inverted Y pattern shows 7% of the prevalence. This is the picture showing V shape, I shape, Y shape, I shape, etc. Coming to the histopathology of the pits and fissures, the orifice of the fissure are and is represented by two bilateral lesions in enamel on opposing cuspal ends. The lesion progresses and depth of the fissure wall becomes involved. Two lesions coalesces into one of the base of the fissure. The enamel at the base is affected and the lesion spreads laterally along enamel adjacent to the depth of the fissure towards DJ. The cavitation occurs owing to loss of mineral and structural support from affected enamel and dentin, resulting in a clinically detectable lesion. Going to the pits and fissure sealant given by Simonson, material that is introduced into the pits and fissures of caries susceptibility, thus forming a micromechanically bonded protective layer cutting access of caries producing bacteria from their source of nutrition. Coming to the history, had in 1923 prophylactic podentomy. He named it as a prophylactic podentomy, filling with the silver or copper oxyphosphate cement. Bodecker in 1929, he found the fissure eradication because fissures are the main reason for the formation of the caries. Bionokov in 1955 found the bonded resins which avoids the formation of the pits and fissures. In mid-1960s, first material used experimentally was cyanoacrylates, but were not marketed. Later, in 1965, Bowen introduced bis-GMA, that is bisphenol glymetacrylate, which was developed. Coming to the classification, according to the chemical structures of the monomer, the MMA is methyl methacrylate, techname is triethylene glycol dimethacrylate, BPD is bisphenol dimethacrylate, and bis-GMA is reaction product of bisphenol A and glyceride methacrylate with the methyl methacrylate monomer, ESP monomer, PMU, propyl methacrylate uracil. Based on the generations, first UV light, which is of 356 nanometer, second cell for chemical cure, the third visible light is 430 to 490 nanometer, the fourth one is a fluoride releasing pit and fissure. These are the pictures of the pit and fissure sealants which are available in the market. This is a 3M company, and this is a Ivoclar pits and fissures that is composite, which is the most commonly used. The brand name is Illusil. This is an embrace with bond. This is one of the advanced pit and fissure sealant which is used even in the wet condition, because for a pit and fissure sealant the isolation is more when compared to the other procedures. The bonding strength is important. In case if the bonding is not proper, the pits and fissures will come out automatically. In case of wet bond, it will adhere in a good manner. Based on the filler particles, it is classified as unfilled. Based on the color, it is classified as clear, tinted or opaque, or colored. Based on the curing mechanisms, it is classified as autopolymerized or light cure. According to the age ranges of sealant application, 3 to 4 years primary molars are indicated, 6 to 7 years permanent first molars are indicated, 11 to 13 years even the second permanent molars and premolars are indicated. These are the other indications where pits and fissures sealants are indicated: deep retentive pits and fissures, stained pits and fissures, questionable enamel caries in pit and fissures, morphology of pit at risk of caries, routine dental care with active preventive dental program. Contraindication is well coalescence, self-cleansing pits and fissures, radiographic or clinical evidence of interproximal caries, tooth not fully erupted, isolation not possible, life expectancy of tooth is limited, and also in dental caries. The technique of application is: first, isolation should be proper with the rubber dam, and tooth preparation should be done with the fissurotomy burr, and acid etching is done with 37% phosphoric acid, and then rinsing and drying of tooth surface, application of bonding agent, then cure, application of the sealant and curing the sealant, and explore the sealed tooth surface, then evaluation of the occlusal surface. Coming to the isolation of the tooth, this is the isolation which was done by the rubber dam, or in case of rubber dam is not available, you can do it with the cotton rolls or pellets with proper sectioning. The tooth preparation can be done with a slurry pumice mix and water. In some cases, air ablation with aluminum oxide also indicated, which was given by Professor in 1992. This is the prophylaxis. And this is the acid etching picture, which was done by 37% phosphoric acid for 30 seconds in primary tooth and 20 seconds in permanent tooth because of the enamel rods pattern. And these are the zones of etching that were given by Silverstone in 1975. The first is narrow zone of enamel is removed, which is of 10 microns in depth. Second one is qualitative porous zone, which is of 20 microns. Third one is quantitative porous zone, which is of 20 microns. Coming to the enamel surface, these are the resin tags attached to the enamel pores. The types of etching pattern are: type 1, generalized buffering of the enamel surface with distinct hollowing of prism surface, and type 2 is prism core sap left projecting towards original enamel. Type 3 is shown neither type 1 or type 2 but generalized surface. Rinse and dry edge surface. Those rinse with air, water, spray for 30 seconds, dry with the tooth for 15 seconds till the white frosty appearance to be seen. Then application of the bonding agent improves the sealants, wetting of the surface, increases the bond strength. Here we can clearly see the application of bond sealants over the groove and then curing the surface for 30 to 40 seconds. And again explore the surface whether still there is any porosities or pits and fissures are available. Finally, check for the occlusion, recall, and reevaluation. The current status of the pits and fissures are: these are the recent advancements with fluoride releasing sealants, which releases the fluoride continuously so that it prevents the tooth surface from the caries. The clear pit and fissure sealant shows with minimal color difference in the tooth surface. The color pits and fissure sealants which will be available in different colors, pinks and green colors, because it will be more attractive to the children. These are the fluorescent pit and fissure sealants. And particularly this is a wet bond, which I earlier told that even in the wet condition, the sealant will set. And this is one of the recent advancement with ACP, is amorphous calcium phosphate. It is one of the best remineralizing agent. Coming to the preventive resin restoration, it is a natural extension of the use of occlusal sealants. It integrates the preventive approach of the sealant therapy for caries susceptible pits and fissures with the therapeutic restoration of incipient caries with composite resin that occur on the occlusal surface. There are three types of based on the extent of depth of. Type A is suspicious pits and fissures where caries removal is limited to enamel. Type B is incipient lesion which involves the dentin, small and confined. Type C is greater explanatory preparation. LA is required. The main difference between a normal pits and fissures and preventive resin restoration is where we need a local anesthesia and preparation with the round burr is necessary to remove the caries. And whereas the other part is similar to pits and fissures, itching of the tooth surface, sealant application, bonding agent, calcium hydroxide liner in case of deep caries, and then composite resin is placed with the plastic instrument and then cured. This technique in type A, clean the surface, isolate the cotton glue, remove the decalcified pits and fissures with a slow speed round burr, etching gel placed for 20 to 60 seconds, then wash and dry, apply the sealants, polymerize with 20 seconds. In type B, remove all the caries and then place liner and then place the composite resin. Type C, where the caries is deep, so sensitivity will be there. So please check for sensitivity and then place a calcium hydroxide base and then add some composite and then cure. Coming to the conclusion, hence pit and fissure sealants and preventive resin restoration plays a major role in